The second half of our presentation is provided by Martha Ferrara, the Device Clinic Manager of Valley Hospital in Ridgewood, New Jersey. Ms. Ferrara has been a nursing professional for more than 35 years. She's seen firsthand the value and benefit of shared governance, and her extensive experience with implantable device patients enables her to share unique and powerful insights into how any device clinic team can build an effective pathway for device patient care management.
Hi everyone, my name is Martha Ferrara. I'm the Device Clinic Manager at Valley Hospital in Ridgewood, New Jersey. Thank you so much to ScottCare for allowing me to just share some of my experiences. Dr. Mittal, that was wonderful. Thank you all for spending an hour with us on a topic that's near and dear to my heart, CIED remote monitoring. So that we are all on the same page, we know that remote monitoring is the standard of care. That horse has left that barn. The Heart Rhythm Society has provided in their Expert Consensus Statement in 2015, which is an update from the guidelines of 2008, on how to do remote monitoring of our devices. In order for me to make sense of what I do, I need to paint pictures in my head. So the guidelines and the responsibilities and the roles of the team members have been outlined by the Heart Rhythm Society in pillars. Leading that charge would be your patient and your physician responsibility. The cornerstone of those remote monitoring programs is your mid-level practitioners, your nurse practitioners, your PAs. And the rest of the team would be your allied health professionals, your ancillary personnel, the institutions and clinics that you work for, third-party vendors, and industry. Now, for me, I have engaged in doing this for a long time, and basically, I need to just make sure I can boil down this information so that I can be quick and digest this information for the team members that work with me. So to me, remote monitoring starts with that teaching that the physician does to that patient, and the patient can no longer disengage himself from this process. Patients are now actively engaging in a process that they need to be taught how to do. That starts with your physician. Your nurse practitioners, your mid-level providers have become your CIED alert managers. They need to look at these alerts on a daily basis, and they run your remote monitoring clinic programs. I truly believe that your allied health professionals and your ancillary staff are the backbone of your clinics, your on-site clinics, your remote monitoring clinics. What I do in my clinic on a daily basis is, when I say a climate of collaborative learning, that means that I share with my staff what happens. They share with me any important findings when they check these devices. Anything that happens there, it's basically something that we all want to know so that we can become better at what we do. I think of my clinic as we all grow each other in that clinic. And our institutions that we work for should be able to provide the tools that we need to do this job. You know, they should provide us with EMRs and with EPRs. Our electronic pacemaker records shouldn't be something that we just hush-posh put together and we use. You should have an EPR just like you have an EMR. Pillar number 8 for me, that would be, I'm going to skip 7 for now. 8, it's industry. Industry has always been supportive of remote monitoring, but I really think that they missed the boat because they created another job description when they invented remote monitoring. It's another job. Our third-party vendors, that's our 7th pillar, our third-party vendors, whether they are someone that you hire outside your clinic to do this work or your staff within staff in your on-site clinic, it is a completely separate group of people doing this job. So historically, we used to do this every 3 months. Whoever worked in the clinic, your physicians, your nurses, your technicians, they would do this check of the device. Patients would come in if they were symptomatic, if their referring physician asked them to have an extra visit, or they were making up visits. That's how we started in my clinic. And then you would do a monthly, heart failure patient. Now, remote interrogation and remote monitoring, once it was instituted, it became part of the regular workflow that you had. And remote monitoring was an option. It was offered as an option to patients. When you incorporated all this work into the already existing clinic work, it was just overwhelming, completely overwhelming. When patients came to see you, you would ask them about remote monitoring setup. You would maybe check if they were compliant with their, with their remote monitor plugged in. It was inconsistent. And the variability that exists in remote monitoring programs out there throughout the country, it's enormous. It's enormous. That impacts your compliance rates, which impacts your health outcomes and the bottom financial line. So what you need is you need a remote monitoring champion, a remote monitoring science champion. That would be me, to help you get along on how to do this. So how do we do this? For me, it's education, education, education. You need to have your EP, and especially your non-EP doctors, your device clinic staff needs to know what this is. Patients and family members need to know that remote monitoring science is here. This is not an option. This is not an option. And you need to do this teaching systematically. It can be today, yes, tomorrow, no. It has to be a systematic way that your nurse, your physician, your mid-level practitioners, your clinic staff, we all share the knowledge that we're gaining. You need to have this. It gets distributed for me in an adjunctive manner and in a parallel manner, because you can send your staff out to workshops that industry has to learn about remote monitoring. You can have them log into their websites to learn how to do that. There is a lot of information out there, and more importantly, you can have remote monitoring mentors, those people who have done this before you, so that you don't have the same pitfalls that they did. You can have someone either come in to show your staff how to do this, or you can have your staff go out there and spend a day with someone who does that. I welcome anyone who wants to come into my clinic. New patients are easy to get into remote monitoring because they know nothing else. This is how you will start the patient. Existing patients are a little more challenging. These patients want to have that human touch of coming every 3 months. And that just doesn't work in this day and age. And I explain that to patients. You are blinded. For the next 3 months, I'm blinded. I don't know what's happening to you. So you need to educate patients and their families in what remote monitoring technology is, increasing their knowledge. Basically, I boil down Dr. Mittal's slides from 4 to 8, that information on what remote monitoring can do to health outcomes. I boil that down to one sentence for my patients. The more connected you are, the better your healthcare outcomes are. They get that. So how do you do this? How do you increase your compliance rates here? You start by teaching patients about remote monitoring the next day before they're discharged, because your physician has already started that conversation. When they come a week later for their wound checks, you pair the patient there, because it is so much easier to tell the patient, this is what your monitor is, this is what it looks like, this is how you plug it in, and this is how you press the button when I ask you to send me a remote monitoring interrogation. They get that. You are engaging that patient, and this monitor that they take home belongs to them. It's a very good way to engage that patient first. And then you have to just do surveillance of that device. So this slide here is about 10 years of my experience, and this is how I get high compliance remote monitoring rates for my patients. Your physician implants that device and starts the conversation. Your mid-level provider will then teach that patient before they leave the hospital. You let them go with a remote monitoring literature bag. I call that our red bag, which is what our patients get before they leave. That way, the patient is engaged for the next 7 days. They feel a little better once they go home and they read that. And I tell my patients, when you come back in a week to me, you're going to have a quiz of 5 questions. So you better read that information because I'm holding you to it. That's the patient's homework. Patients can no longer disengage themselves from this process. Now, your third square is your allied health professional. That's the person that comes to your clinic, educates the patient further, That patient, it's paired there, you give them the remote monitor, and now you have your mid-level clinician. That is a cornerstone of your program, because now you have an on-site clinic that you need to run, and you have your remote monitoring clinic on the other branch. Your allied health professionals, your ancillary personnel, then worry about giving patients their schedules, billing for that patient, and your nurses, your pacemaker techs, your allied health professionals see that patient during their wound check. They see that patient 1 month later, and they see that patient 6 months later. And that's it. We're seeing you yearly from here on. It will be a yearly visit for the next, 10, 12 years. Boston Scientific makes a pacemaker that lasts that long. When they're remote monitored, now that they're plugged in, that again is where your virtual remote monitoring clinic comes in. If you follow that slide and you do that for every patient every time with every single staff member in your clinic, you are now doing remote monitoring science into remote monitoring art. This is what I do. And that was for pacemakers, and that was for defibrillators, and now we have wireless loop recorders. Oy vey. It's an avalanche of data. It's an avalanche of daily data. Every day you get a clinical actionable event. You have to do something every single day. So your mid-level provider, the cornerstone of your program, becomes your alert management clinician. If you look at this whole circle here, think of it as laundry. Think of it as laundry. That's the washing machine, and clean stuff comes out. That dedicated staff that you have in your virtual clinic will receive, your triage people receive all that information. The triage personnel sends that to the front desk so that that front desk can do billing and do appropriate scheduling. The triage people will send to their reporters the information that's actionable. That information comes to me and the physician that is attached to that patient. What I do is I look at my EMR and I look at my EPR. I see this patient. I then look at the plan that may have been formulated by the physician, or I ask the physician, this patient is so and so and so. Should we do this? My clinicians, my physicians answer me, and they don't have to be in the clinic. They send that information to me with the emails. We put the plan together. We send out that letter. We make that referral physician happy. You call the patient, and the patient is very happy for you. Now, if there was ever a marriage in CIED heaven, that would be atrial fibrillation and loop recorders. It is daily data. You want to tame this data deluge. So we've gone a step further in our clinic. We have subdivided our main clinic into a heart failure clinic, a device clinic, and we have subdivided our link clinic into the different diagnoses that you will see. This label matches. Dr. Mittal, myself, and the clinic staff actually work very hard on this label because this diagnosis that you have here match your subclinics. Each diagnosis has its own alert, red or yellow alert, and it's very effective because now what you do is you're surveilling these patients for that actionable alert that comes through. When it does come through, you call the patient, you do your clinical follow-up, and you alert that clinician for the plan. Once you get it, you modify that alert. So that patient will not remain the same. You're modifying alerts. You really, truly are taking care of this patient. You call the patient, you send that report to your physician, everyone's happy. Keeping your referral base satisfied, them being happy with the work that you do, and you don't have to do it in an hour, but if you do it within 24 hours, you really buy their trust. For me, I'm a nurse 35 years. I'm an old shoe on this road. Managing a device clinic sounds to me like shared governance. Shared governance, because this is a team effort. This is not a one-person job. This is a team effort. We are all partners, and accountable for the fair share of the work that we all get, we need to have a framework that we can follow so that we can sustain the work that we do every day. This is long term. This is long term. And mentoring has to become part of remote monitoring science. Please don't let me fall in this pitfall if somebody already knows how to avoid that pitfall. You need to mentor this staff, this remote monitoring clinic, this clinical staff that's on site with you, the virtual staff that works with you. So for me, a shared governance structure in a digital age, in an era of telehealth, looks like this, and it's held by the pillars that the Heart Rhythm Society guidelines have given us. We are practicing telemedicine to an incredible degree. So your institutions need to be supportive of the work that you do, the work that clinicians do, because at the end of the day, you want to have above standard of care for your patients and for your families. They are important. I'm very lucky to work for the Valley Hospital because they really support the work that we do. And I promise you, this is really true, and maybe it's because I'm just made that way. But every day, my mantra when I come into work is today we are giving above standard of care to my patients because they deserve it. Thanks for letting me share.